Oh, I think, it can seem like our Medicaid program has a lot of challenges, and I admit we do have some things that we need to work on. If you go across the country, I will just say every Medicaid program has challenges and opportunities. So we figure out ways we make the best we possibly. I'm getting that someone can. Everyone else hear me?
I hear you, Liz.
Okay.
Yes.
I hear you.
Thank you. Okay, so some of those challenges include there are just laws where we have to operate within the framework of certain rules and regulations. And then we also have just a number of limitations when it comes to the amount of money that we have available for all of our Medicaid members. Now, I'm not saying that there aren't challenges that we have today that are insurmountable. There are a lot of things that we can get past. There are a lot of challenges that we can work through and make the program better. So that's why I want to be here, and that's why I want to hear from you, because if there's a way to make it happen, I want to work on doing that. As a group, with all of you, as the individuals who mean the most within this program, I want to create a space where we can bring ideas that all of you have and how we can make this Medicaid program better. And I think that I probably have talked to some of you in the past and worked on some of those things, but we have some unique opportunities right now to make actual change. So this town hall process is probably new to some of you, and we're going to work through some of the kinks together, because there's going to be times where people aren't on mute, where people are talking over each other and things like that. And we're just going to have to work through it and be patient with each other. But it's something that we're really excited about. We need all of your perspectives, everything that you're seeing and how the program could work better, because those are the real ways that we want to impact the program for all of you. I know that there have been places and times where many of you may not have felt heard from the program or from, but I'm here to listen, and we are here to move forward and work together. Okay, so in the meantime, if there are things that you have ideas on to improve or topics that you would like addressed moving forward, we're setting up a mechanism to be able to collect that feedback. I don't have that set up exactly right now, but I will put my email in the chat box if you have things that you want to get in front of us. Like I said, and you guys are all doing a great job. If you're not talking, try to keep your phone on mute. It does eliminate some of the background noise that keeps people from being able to hear. If we do start kind of talking over each other, we might have to go to using the raise your hand function on Zoom. I know that that's kind of tricky and maybe not everyone's familiar with Zoom. So also we'll use the chat box where you can ask questions. We are transcribing everything from this call so that we can follow up with individuals and bring information back to the next town hall that we aren't able to address today. All right. So with that, I do want to introduce some folks that I work with here at Medicaid, because they are really the ones that do the work. They have the heart, and They are super dedicated. Many have been with the Medicaid program for a number of years. They choose to do this because they believe in the program and they want to do good for the state of Iowa. So Julie, I'm going to kick it to you.
Good afternoon, everyone. I'm Julie Lovelady, and I'm the Deputy Medicaid Director. And I just want to thank all of you for taking time to join us today. And we really do look forward to hearing everything that you have to tell us so that we can continually make the program better for everyone.
All right, Jennifer.
Sure. Thanks, Liz. I'm Jennifer Steenblock, and I am the Federal Compliance Officer for Iowa Medicaid, and I support our Medicaid team in ensuring that we're meeting all the federal requirements as it pertains to our program, but also keeping an eye out for those new initiatives, new things that can happen, and making sure that we're following all of the guidelines. So we are happy to hear is that you have for us to.
Thanks for Paula, are you able to join?
Hi, Liz. This is Paula Motzinger. I am the Bureau Chief of Medical and Long-Term Services and Support Policy Bureau for Medicaid. And my team is responsible for setting all of the policy for hospitals, physicians, clinics, and also our home and community-based services. And I am so happy to have all of you on the call today.
Thanks, Paula. Amela?
Thank you, Liz. Hi, I'm Amela Alibasic, and I'm a Bureau Chief for Medicaid Eligibility Policy. My team is responsible for managing the Medicaid program related to Medicaid eligibility, long-term care programs, facility eligibility, state supplementary assistance, and refugee medical assistance. I also would like to thank you for attending today's call, and that I'm looking forward to the conversation today. Thank you.
Thanks, Amela. I didn't see that Mary joined, so maybe we'll catch her next time. Okay, so I did want to give everyone a few updates before we kick it off for questions and feedback. One is that we were really lucky to get some appropriations from the legislature this year to increase our provider rates for home and community-based services and habilitation services. So we're very excited about that. We also got some additional money to increase rates for PMICs and a handful of other providers. We're in the process of getting those put in place, and just, you know, if anyone has a question as far as when those rates truly are effective, they are effective July 1st of this year. So they will go back, and if claims have already been submitted for any of your providers, they'll reprocess that at a higher rate. Also, I want to thank all of you that participated in town hall that we had a little while ago. So I think that was earlier in July, related to we got from the federal government on how to make the HCBS program better. So if you haven't seen that plan, I'll put a link into, or Kevin, maybe you can put a link into the chat so that you guys can all see kind of the fruits of your input. We did take a number of pieces of feedback from all of you to weave in, including development of a direct care registry that you can go to if you're looking for a personal care provider. We want to make that be as robust and user-friendly as possible, so that if you do need a provider, you can go to that site, look for providers in your area that provide that consumer directed attendant care or CCO services, and see if they have, for example, gone through training, already enrolled with Medicaid and things like that. So we are working to get those things implemented. We need to wait for CMS, our federal partner, to approve our plan though, and we haven't heard that yet. We are also looking at getting some experts into the state to look at overall different services that are provided, for mental health needs, any type of service need for individuals with an identified disability, aging related resources, because ultimately what we want to do is make sure that we are leveraging Medicaid dollars the most effectively. So we're getting Medicaid services to the most number of people possible. And that if it looks like it makes sense to have similar services available for everyone, regardless whether on health and disability waiver, really looking at how we can just waivers are more in line with what people need today, because some of those documents were really developed quite a while ago, and we know that the world changes and needs change, and we want to get consultation. We want some people to come in and tell us what could make those better. Okay, so do look at a plan. If you feel like it would be beneficial to walk through it more at the next meeting, I'm happy to do that too. We can get some more team members on to describe it more in depth, and hopefully we'll have heard from our federal partners by then that it's approved and we can actually get some projects going. Okay. Well, I will start with the chat, but if anybody has something to say, please feel free to chime in as much as possible. So Shelley says, I would like to talk about changes that won't cost money. Terrific, terrific viewpoint. So when we're thinking about service expansion, we need to be doing a better job, or maybe get some help in doing this, but looking at, one service might cost more if we increase a rate or make it available to more people, but maybe down the road, it avoids a hospitalization or something that is more costly. So I like where your head is at. That's where we are at too. And those are some things that we will be working on. And if you do have some specific ideas, we would love to hear those.
Can I just say something quick? Some of my ideas. Well, the CCO program is amazing. It was great when it started, and then it went, and I had to get off of it years ago. And so I'm back on it, and I'm managing my own care. I'm hiring, I'm training, I'm doing all that because I got an exception to policy to pay better, and it's worked out great. And I want to keep that going. And so if the pay rates were increased with CDAC cares, personal cares, to match more in line with respite and SEL, because those are more to $20 an hour, like starting point, but they take out taxes and fees. I understand that. So with a higher pay rate, it helped me more caregivers. With if we were able to get SL services, not everybody can drive. I can, and that community aspect, also job support employment because I work, and with CDAC, sometimes it's not ensured that I'm going to get to work if somebody's paid $9 an hour. But if I had more of a job, like they have job coaching, so if they had support employment for people with physical disabilities to be able to get out of bed to know that they're going to get to work, more of us can work. And as you know, I like to use my voice. And so if I could use my voice in working more rather than advocating more, you know, it's more useful. I'm getting more taxes. I can get off programs maybe. So things like that are very important to me. And the community living aspect for my friends that don't drive, that live in small towns. The transportation services are not providing enough wheelchair accessible transportation. People are having to cancel appointments for things, like my friend Kyla, who's on this call. She is trying to get voice activated training because she's losing her voice, and she has stuff to say if they'll let her speak at some point. But it's important that for her to learn that, and she couldn't go to learn that today, so she had to cancel her appointment because of no transportation. So, oh, and family supports, they should be paid. Unpaid natural supports are ridiculous. People shouldn't be working 18 hours a day for free. So I can go on, you know me, but appreciate it.
Thanks, Shelley. Hey, on the transportation, not providing enough wheelchair accessible options, do you think that they don't have enough of the vehicles to support that, or is it about drivers, or do you have any idea as to what might be the root cause of that?
Kyla, if her voice is okay, could speak, or Jen might have some information, but I think it's a lack of vehicles. And so when they're going, sometimes somebody will go pick somebody else up and they won't have to wait. Kyla has to wait an extra hour for her doctor visit and then wait an hour to leave the doctor. So it takes the whole day just to go to the doctor. Kyla, do you want to type in the chat, or do you want to speak to that?
Yeah. What happens is, if a dialysis person has a preferred ride, that company can take them in a wheelchair. And then if they're not using the wheelchair, it takes you transportation. There's two companies, but I don't want them. They are unsafe. They don't tie down my chair right, or my chair has almost split being loaded.
Thanks, Kyla. That's really helpful. Okay, maybe I will take that back and have some conversations about how we can get some more transportation available in the state.
Like MCOs.
Oh, and I guess I didn't explain the part where it wouldn't cost more money. The point with that is, if I have better pay rate, but I'm not spending more with my waiver right now because I was approved for a certain level of care, but I'm not spending more, because with $10 an hour, you can't hire the people. So you just don't spend your waiver, and then it goes wasted, and then you're stuck at home sitting in bed for 48 hours. So that's what I mean about not spending more money. It's just being able to use our waivers effectively with the services.
Yeah, I love that, Shelley.
So I'm done. Thank you so much.
Thank you. Okay.
Excuse me, can I just add something about the quality of the pickup service? Hello, thank you very much for holding these town hall meetings. Because I've used them, but I'm very reluctant to now. I often found that they were texting and driving, looking at their, even the, normal lady, not the person who looked like he's just had a night out on crack, the quality of the drivers is, needs to be looked into. And then when I made a written complaint, they told them I was identified to that company in Ottumwa. And so that made it very uncomfortable to ring that company again and then get that same driver, or someone said, no, she doesn't like me. I'm not going to drive for her anymore. Was relayed by another driver. So, that would be good to have better enforcement there if you could, please. Thank you.
Thanks, Patricia. I appreciate that feedback. Certainly, it's not a great situation when you provide a complaint and then you're kind of put on the spot with someone you depend on.
At another company, I was able to have a procedure and anesthesia up in Fairfield, and you know, the driver was in a big bus. There were like four, an enormous bus, and did a whole round trip, you know, till waited at the doors at the hospital, the little hospital, by the time, you know, the bus came. So it was very, very late. And then the driver says he's been up all night, you know, didn't get any sleep the night before. And that's happened with the place out of Ottumwa. I don't know where the place, you know, I can't remember the name of the place that took me from, I think it was, sorry, I can't remember the name of it. It was Unity Point. I can't remember the address, but that's a common thing with the drivers, you know, is seems to be a common thing where they've been up all night the night before and then come and pick you up at 9 o'clock in the morning and then come back to pick you up in the afternoon. So tiredness and texting. Thank you.
Yeah, thanks, Patricia.
Regarding the transportation, this just came up now. CCO allowing transportation. I had quite a discussion back and forth with our case manager, with Brian Wine. And finally, you know, Brian did explain it to where our case management agency, the MCO, basically understood that under CCO, my son's direct support staff can transport him, bill for his SIL time, and get reimbursement through the CCO budget that is a, I don't know, goods and services. So for people that are on CCO, if they have a direct support person who can provide their transportation, because during the pandemic, we did not want to use a company. We didn't want our son exposed. So it's really important, I think, you know, and if what I'm saying is correct, Liz, that you verify that for people. If you're on CCO and your direct support staff can and will provide transportation, it's a big help if they can get reimbursed for their mileage versus the cost of that. So that's what we're doing right now, because we can't get a transportation company. And it's in his budget. It's in my son's budget under reimbursement for goods and services. I mean, there's a certain amount of money there. And it's designated for mileage reimbursement.
With that same thing that Kay is talking about with people. And even though it's allowed by Iowa code, there's many people that the MCO are telling it is not allowed and not letting them have the transportation.
I mean, that's what we were told. We were told no by the case manager and her supervisor at the MCO. So I questioned it. And I figured I'll just go to the person at IME who's in charge. And Brian Wines explained it very well to me. I have to say it took a little while for the people at the MCO to understand and agree with what your program director was telling them, Liz. So they need to stop telling people that they can't do that. If their budget is, if their CCO budget is set up to have that reimbursement for goods and services to include transportation. I mean, that's all about self-direction. you know, and setting your budget. But it's an issue if MCOs are still telling people they can't do that. That's wrong.
Right. It's not a matter of once they went through this with Kay's son, then they went, oh, okay, I see how we're supposed to be doing this because it was explained to us by someone. They only fix that one situation.
Mm-hmm.
Literally have to go back through trying to contact somebody to tell them what to do, and this can drag out to 2 to 3 months. And I know of somebody right now going to a state fair hearing over it.
It's a systemic issue. It's a systemic issue that y'all can correct.
And there's different miscommunication. I mean, there's like they're telling different stories of why this isn't allowed or how come that isn't allowed or this. So like it's not even consistent in the reasons you're getting. It's just, I don't know. I don't know what else to say. I just thought I'd pipe in and say, it's not just you. I know of cases.
Well, Kay and Leah, very, very helpful. We have some work to do on our end.
Thank you so much.
No, thank you.
Is this a point where people just give comments, or, I mean, was that a question directed to Liz? I mean, is there an answer that anybody wanted from Liz on that issue?
I mean, I got the answer I wanted, that she recognizes she's now aware of this issue and they're going to take care of it. So we'll see. I think, you know, hopefully it'll get better.
Yeah, can you give a date when you're going to fix it so that we have a timeline here, so that it's not just a talk fest today and, you know, being patronized and say what a good comment and everything, because a lot of us are pretty angry. I'm pretty upset about AmeriGroup. I've supposedly had services for 3 years and I haven't been able to get services because I can't pay enough money. You know, it's ridiculous, the allocation rate. And then I said, well, you know, the people who come with that are, you know, just don't have the skills to be a carer or work with the, you know, elderly. And, you know, it is a special skill and they need to be higher paid. And the people you can get are unreliable, do a bad job. So I said I was willing to sacrifice that so that I could pay market rates in my area, which are much higher than Des Moines. And AmeriGroup cites 2 sections of the code. The code needs to be rewritten because, you know, they just get their fancy lawyers back in, you know, wherever they're headquartered and read all the fine print of the code and say we don't have to do that. And in the meantime, it's years and I haven't had proper or full services. And so we're supposed to be allowed to pay market rates, but then they say, well, no, you have to work the hours that have been allocated in your budget. Well, if I do that, no one works for, you know, $9 to $11 an hour. And, you know, I'm sorry, but I feel it's, you know, it's a disgrace how Iowa treats their elderly and disabled. And I know I'm much better off than, you know, less disabled than a lot of people, but, you know, I want to stay in my home. You need to, you know, up the game and so that we can get repairs and maintenance, you know, done so that allow us to stay in our home. And, you know, you're just the way it is with chore services and homemaker services, it just got a pipeline to nursing homes because people can't stay in their homes because you can't maintain it. And so I don't want to join that pipeline. It's like a holocaust for the elderly and disabled. It's not fair. And, you know, you're not trying hard enough. We've had all this and now you've got all this money and, you know, I'm not hearing anything about doubling, tripling the allocation rates to the budget. So, you know, could we have a timeline on that? You know, it took 6-8 months or whatever to get to my MCO to even reply to an exception to policy. And they said, well, we're doing it this way because, you know, you've got, you know, appeal rights to the state fair hearing. And, you know, then when I got the letter unsigned, no name on it, just like a form letter, you know, I was unsuccessful. They cited 2 areas of the code that, you know, were not correct. And I have, you know, a very good ISB now in Leah Price, and she tried to point out that that was wrong, but there's nothing you can do. You know, the MCO, they just wear you down until you give up. And, you know, it's not the right attitude. The case manager says one thing and, you know, you don't get anywhere. I should be able to pay market rates in my area, which is what the code says, but then the other part of the code contradicts it. So, you know, there's a whole lot of, you know, people have been so nice in Iowa. I'm not as polite. I'm not from Iowa, but I do stay here because I like the people. But you can't treat Iowans like this, seniors and people with disabilities. You discriminate between disabilities. You know, why is it that I get, you know, 40 cents a mile for trip reimbursement, and someone in, you know, under another waiver gets, you know, much higher reimbursement rate, mileage reimbursement rate? That's clear. You know, we don't discriminate between disabilities. Well, under the, you know, Americans for Disability Act, that's discrimination because you're treating people with different disabilities differently. So thank you for listening.
Absolutely, Patricia. So, you know, I think that you started off the comment with, you know, what's the timeline? You don't want to have someone tell you it's a good comment and then never follow up. Listen, I absolutely get that 100%. And I'm committed to doing these town halls every, and it's going to be really painful for me if I don't prove my point or prove to all of you that I'm going to follow up on these things, right? So I think it's in all of our best interests. It's in the interest of this program to make sure that we're following up on these issues. And when we see systemic issues identified, absolutely, it's going to be my first priority. Tomorrow morning, I've been texting people right now to start following up on it. So I do plan on getting an answer back. Like I said at the beginning of this meeting, we're going to be transcribing all of these calls and town halls, and we're going to be getting feedback back to the group. You know, we can't speak to specific individual circumstances, but we certainly can talk about issues that are identified. And then let's see, on the CCO transportation issue, definitely we're already starting to follow up on that. Patricia, what you talked about related to the inequity in the waivers, I probably wasn't as clear about this at the front end of the meeting, but we did get some dollars from the federal government to invest in making our program better on the HCBS side. And so that includes doing an evaluation, and we're going to be looking at all of the waivers to address some of those equity issues. I do agree with you. Each one of those waivers was developed quite a bit ago, maybe even a couple of decades ago, and not really substantially changed since then, but times have changed, and we need to adapt our waivers to meet your needs, Shelley's needs, Kay's needs, everybody's needs on the call. That's going to be a big project, though. I'm just warning you. So just full transparency, that's going to take a year probably of an evaluation, and then we're going to have to get CMS approval.
So
sorry, if I could just finish there, the paying market rates in our area, it's clearly stated in the code, and we should be able to decide that. That's why we've got a flexible budget, and we should be able to pay the rate that will attract people. should be done immediately. And just send a direct clarification on the code to the year to do that.
The clarification piece on the transportation side, yeah, you're right, that's easy.
And
I mean, on getting services, clarification on interpretation of the code and paying market rates for homemaker and chore services.
Yep.
Should be able to do that without having to stick to the number of hours worked, because right now I haven't had anything. Mary Group has been taking all that money for those years, extra money that for services I haven't gotten. So, you know, clarifying the code is very important so that we can pay market rates for our services in our areas.
Liz, if I could, in terms of the rate, you mentioned there's been the appropriation to increase the rates for home and community-based services effective July 1st. You know, y'all are getting that together. I put it in the chat, but I think it's a yes or no answer with maybe some clarification depending on yes or no. Will that rate increase of 3.5%, is that available to CCO providers? And if yes, do we redo our budget to be able to use that rate increase? How's that working? So number one, is the rate and reimbursement rate to providers available to people using the CCO option?
Paula, are you aware of the impact on CCO rates?
Yes, Liz, it is actually available to CCO providers as well. The increase is for all HCBS providers, including CCO. The way that we'll see an impact to members is that they only have a limited budget, and so they will have to ensure that the members' needs don't, or the services don't decrease to provide that pay increase for staff. That's where we're going to see the biggest impact.
And so should we be hearing from our case manager, from our independent support broker about doing a budget revision?
Yes, if you have not had those conversations already with the case managers, you should absolutely do that with the case managers and the independent support brokers.
Okay, well, let me just throw this in there. I did contact our case manager with they were total care, and she was told by her person that this rate is going to be going to the independent support broker and the financial system, Veridian. So
yes, so Veridian received an increase because they are an HCBS provider, and independent support brokers received an increase, and the CCO providers should also receive the increase.
Okay, as far as independent support brokers go, we have got no knowledge of this other than just where everybody else is getting their knowledge, at least not as an independent support broker. And what I know as an independent support broker is there are going to be steps that this has got to take. The case manager is going to have to develop different dollar amounts to go to the independent support broker to develop a different budget, which if this is for all services and it's the same percentage, we could possibly come up with and figure that on our own, but we wouldn't know that we were on the exact same page with the case manager. But there is nowhere to look up CCO rates. CCO rates, they take the traditional rate and there's a utilization factor that they use to come up with CCO rates, which are in the system. So they're in the case manager's system, not anything that Veridian has access to or independent support brokers have access to. What we currently as an independent support broker have access to is a spreadsheet chart that someone's came up with based off of the numbers that were in the system. When will independent support brokers be able to get those new figures?
So everybody received a 3.55% rate increase. And so you should be able to take the rate that you receive right now, or you received prior to 7/1, and add 3.55% to that.
Okay,
And
so
those rates
you
are
tell us-
effective.
I know that there's a, like, I don't know what the formula is, but something like the utilization factor takes into account a certain percentage, like maybe 70% of something times this or whatever. So I don't know if that 3.55%, it depends on at which point you add that. Do you add it after you do the utilization factor? Because then we could just do the math and figure it out. But if you do that before you do the utilization factor, we would have to know the exact utilization factor process for each rate.
Paula, can we work on some pretty descriptive instructions and get those out in informational letter?
Yeah, we can do that. And I think it's important to remind individuals that we do have that CCO work group that Brian is implementing. And so we can answer some of those questions through that as well.
I think we have probably an immediate need of getting people's rates updated. We'll get an informational letter out ASAP.
Okay.
Yeah, and I don't know if Brian has updated. I don't know if Brian has updated the utilization factors yet, so I'll have a conversation with him tomorrow.
Okay, and is there going to be a way for CCO to go back and utilize it for back to July 1st? I mean, I saw where those adjustments would be made for claims submitted with like traditional or however that works. I don't work on that end. You know, there would be an adjustment going back to July 1st. Will we have a way to do that with CCO also? Because I mean, if we do not, then we're already out July and August. And if new budgets aren't in like very soon, people won't be able to use it for September either.
Yeah, I'll have to reach out. I'll follow up with Brian and get some information back to communicate to everybody somehow. Because, yeah, it was my understanding that the rate increase was for all HCBS providers, including CCO. So again, I'll follow up with Brian tomorrow and see what we need to do to get the utilization factor updated and all of that.
Yeah.
There's a informational bulletin that's already online about this. And I believe there were some services that are automatically updated, for example, SCL 15-minute units and daily rates. But I believe the process for CCO was that a member has to request of their case manager that they increase those rates. I believe there's wording to that effect in that informational bulletin. I guess my question is, why would you be leaving it to members or individuals to request of their case manager that rates that supposedly have been automatically updated or are to be? Why are you leaving that to members to request out of their case manager and then place the note in their file?
I would add to that. I have asked my case manager, who is not an MCO case manager, about that rate increase. And for CCO, in that answer as to whether it applies to CCO, so it needs to be in writing somewhere that we can refer back to that this is, yes, applicable. She has no problem doing that for us, but she just didn't know if it did apply or not. So I think there is confusion. So guidance to the MCOs, case management, and you know, letting ISBs know as well that that's because that means that there's a budget that needs to be redone for every CCO member, and whether it's moving forward or retro. If you retroact those, it's complicated. So, and I get that, but at least moving forward, it would be nice to get those done.
And we also
I'll have a conversation.
People that
I'll
don't.
have that conversation.
Sorry.
I'll have that conversation right away tomorrow with Brian to figure out what we need to do to address the whole utilization factor so we can move forward on this.
Yeah, we need to account for the people that are unaware that this is happening. We don't want to leave them out just because they don't know.
Yeah, Leah, I think that it's pretty clear that we need some clarification here. So we'll make it a priority for tomorrow to get something put together. This has been a great dialogue, and thank you for bringing it forward. Hi, Kyla.
Hello, my name is Kyla Claussen. I am from Avoca. Many things need to be changed, from waiting lists to transportation. Anybody could acquire a disability at any moment. I'm on the waiting list for the physical and health and disability waiver. I've been on it for about a year now and probably have about 2 to 3 years more to wait. As a person with a progression disease, we don't have time to wait for help to stay in our homes. We lose some sort of independence daily. Calling DHS for suggestions, you shouldn't be told to call 211 for help. I shouldn't receive phone calls from an AmeriGroup outreach worker suggesting to go to assisted living when they don't do skill cares. I think removing the enrollment slot cap for the physical disability waivers would benefit any one of us who is an acquired disability. I don't want to go to a nursing home. Thank you.
Thanks, Kyla. We don't want you to live somewhere where you don't want to live either. I mean, ultimately, that's why we're all here to talk about these subjects. And some of these conversations are tough, and they aren't always easy to rectify right away. But here's what I'll say. I'm at the table, I'm listening, and I'm committed to starting to work on it. And you have a lot of people on this call, including Paula, including Brian Wines, including Leanne Moskowitz, and a whole other team of people that really do want to do what's best. So I do want to thank you all for providing this feedback. We obviously have some work to do on how we roll out rate changes and communicating with everyone globally. I think that we think that we're doing a good job, but I can see right now that we have a lot of work to do. So we will work on it, and we'll come back next month and talk about some of our plans on how we'll roll things out a little bit better. But the purpose also of this town hall, through the months and years to come, is that as we're talking through some of these changes, whether they're rates or policy changes, we'll be talking to you in advance of them actually rolling out. And we'll be asking for feedback and what's going to be helpful in getting those things going. Because ultimately, when you say, Liz, remember last year when everybody had those questions at the CCO meeting, that will probably already be at front of mind, but it's important not to repeat our mistakes where we can, right?
I had a question about, so I noticed that the HCBS Providers Manual was updated a lot of it was updated last September. Some of the updates that came, I've seen a lot of changes with like SCL. There's some wording in there about, especially for those under the age of 20 that receive SCL, if they need beyond intermittent, it says now that they need to it through EPSDT and have a home health agency request. I think the home health agency is supposed to request it through EPSDT. I have asked about this process because this is new, that those are new changes. I think before the case justify it in the care plan. Now it's unclear as to that process and to get beyond intermittent. challenging. I have called the EPST. I could find 1-800 number to ask, and that was over 2 weeks ago, and I have not gotten a call back. So I don't, it's been difficult to find those answers for myself, and I'm also an ISB. I help other members utilize those services. And so I've seen MCOs just say under the age of 20, you cannot have more than 52 hours of SCL, which is not what that says. And it's not what the Iowa code says either. So it doesn't feel like it's quite in line. So they're not willing to go through the steps to really evaluate and see how much this young adult or child may need. So I don't know where you go with those questions here. Is there someone you can email when they're not in line with one another?
Well, for now, you can email me, and then we'll get we'll get something else set up so that we can have a round robin approach to tackling some of these issues. But I'm going to put my email in the chat box. Shoot me what's going on.
That's much appreciated, Liz. You know, there's also other issues where the policy manuals aren't aligned to the administrative code. If you read the policy manual for SCL rules, it makes it look like there's an 8-hour limit on services. The policy manuals went from 19 hours a day to 8 hours a day, and now it says 20,440 units for, I believe, the brain injury waiver. You guys are well aware of that issue and the fact that it says in the administrative code that it's 23 hours a day for that waiver, and for BI waiver, and for ID waiver 20,440. You still have case managers out there, you know, telling members that there's an 8-hour day limit. In fact, Kelly Garcia last month or the month before signed off on, she didn't sign off on an ETP, but she responded to the member telling them that that was not, that require an ETP. She had been fighting with the case manager for at least a couple months, and then they drew her down an exception of policy route, requesting the 14 hours. And, you know, then Kelly writes back and says, this isn't required. As you know, this does not require an ETP to request this. The case managers, your policy manuals, and those types of things are still setting out rules that you guys know are not valid rules. You know, in the brain injury waiver that it's 23 hours a day. You know, in the ID waiver, it's 14 hours a day. You have not updated your policy manuals. You have not communicated to field staff or case managers that you know, that is not the limit, you know, that those hours are the limit. It's not 8 hours a day. You have not provided them, you know, any guidance as to how hourly and daily will work, and they try to push everybody onto daily SCL when it's not appropriate, such as when somebody's in the home, their own home, the home of the guardian, and they're not in a group home. You are well aware of these issues. We've went through them probably a year to 2 years ago, and yet your policy manuals haven't been updated. And I'd like to know, why is that the case? There's other issues too. Transportation's another example. Your transportation, in fact, you've put out informational bulletins that have clarified what the transportation was. We all know the ARRCs that were released back in 2017 for the emergency rulemaking that resulted in the tiered daily ID waiver rates. The transportation was combined, but we know that that's not the case with the other waivers and non-daily services. So why is there this transparency? Why is there this disconnect between you know, what you guys are promulgating and what the NGOs are telling people?
Well, Fred, you brought up several very solid examples. I'm going to have to follow up on those myself. I know that that isn't satisfying right now, but if you would shoot me an email so I can follow up with you directly, would be terrific. This as an update next month. But agree, like
Yeah.
the misalignment is not helpful.
On the transportation issue, we're going to a state fair hearing, so I don't know if it's a good idea to talk about
Okay.
just a whole lot. I don't
Okay.
want to get caught with some ex post facto
Sure.
rules, but it's important to realize that, a lot of the reasoning that an MCO gives for denying a service is just contrary to what you're putting in informational bulletins. And to go to another issue with the utilization adjustment factor, is there any way that you can provide us some transparency as to how exactly that number is calculated? I've heard that DRI has requested that information of you and they haven't been given that in the past. How exactly is that number? How do we get from like $9 per unit on a service to $5 a unit on a CCO for the same service? How do we get, are we comparing the CCO rates for CDAC? Are we comparing, are we doing a transfer on the number of what the individual CDAC worker that's contracted with Medicaid is being paid? Or are we basing that utilization on the home health care cost, like through a provider home health network? It just seems like there's no transparency that's been provided to members. And then we're left to go pour through policy manuals and the administrative code and draw inferences, look at press releases and things like that. And then we realize that there's a lot of disconnect between what you are saying and what the MCOs are doing when they authorize services.
Yeah, I
Can I just pop in there? Sorry, that was a wonderful thing you just said, Fred. And, I have to say, I can only say whoever wrote that utilization factor, I'd like to be smoking whatever they were smoking. It doesn't give anything. It's a silly, ridiculous thing. It has to be thrown out, and something with, reflecting market rates, not utilization factors. It's, I am a CPA and I've read that, 6 to 10 times and I do not understand it. It is not a just or transparent way of calculating our rates, and our allocation rates to our budgets haven't been changed in 10 years or more. I don't know. No one knows when the last rate change was. So I just find, a 3.5% rate. It's been really, you've got all this, we have an adjustment, a CPI adjustment for every year since you have not raised the allocation rate to our budget. It's, it's not a just or equitable system, and it's, all for the damages the vulnerable. People have to give up because it's so hard to do anything. And when the MCOs make all these mistakes and purposely try to stop you from getting money, there's no consequences for them. There are no fines to the MCO, no threat to them if they tell you a bunch of lies and a bunch of hogwash that you can't understand. And, and then you say you go to the wonderful MCO ombudsman, a wonderful person, but she can't do anything to, say, well, that's wrong. She finds something wrong, but the MCOs do not get fined or disciplinary action against them at all. So yeah, please promise you're going to throw out that utilization factor. Start again. Don't try to explain it anymore. It's a silly, absurd calculation that people can't understand. Thank you, everyone.
Thanks, Patricia. Well, Paula, for the CCO work group, is that an opportunity where some of the individuals on this call could participate?
Yes, absolutely. We actually would appreciate the additional stakeholder input, and they could bring some of these concerns to that work group. But I can say that Brian and I have already had conversations about ensuring that we address the rate issue and looking at the utilization factor as part of that work group.
Okay, we are out of time.
How do you figure out how to get part of it?
Sorry, Leah, go ahead.
How do we find out more information about this work group or when it will be starting?
Yeah, I was just going to ask one very quick question about that, because
Okay.
there are quite a few people in the chat that, as well as myself, that I've never heard of this work group. So if you could provide us some information on how we could be part of that, or at least witness to it, to see, just so that we can use it for our own personal information, that would be very
Kevin,
helpful.
Yeah, thanks, Tucker. Kevin, could they let member services know that they're interested?
Yeah, we could do that. We haven't gathered the group together yet, so we're still kind of formulating when the group is going to meet and who's going to participate. So yes, we're definitely interested. If you wanted to send your contact information to member services email, I'll put that in the chat box, and then we can kind of go from there.
Oh, Lindsay put it in there.
Thanks, Lindsay.
So all we would need to do then is just say that I would like to be part of this group, just so that, is there something that we should put in the subject line so that that gets flagged correctly?
Yeah, put CCO work group.
Do we have any kind of idea of when this is going to be starting? Because I was originally told we would have something going by July, and then told June, maybe even the end of May, and then told August. And this is stuff I was been told since February. So do we have any realistic timeline of when this might actually get going?
Paula and okay, go ahead, Paula. I was gonna say Paula and I are committed to getting it started by the end of September.
Thanks, Liz.
That's right, Paula?
Sorry, I had to take myself off mute again. Yes, we will have it up and running by the end of September. I will work with Brian again on that in the morning. And I apologize. The intent was for us to do that in late July, early August. And we just had some competing priorities with the ARPA dollars. And so I will make sure that I have a conversation with Brian tomorrow to get that up and running.
So we are over time. I could talk about this for hours. These aren't, I'm serious, Fred, I really could. I'm not, I don't wilt.
Of course we could talk for hours.
I can listen for hours. These are not always easy conversations, but these are things we need to hear. And we need individuals like you that can articulate things. I mean, everybody has been so great at giving real life examples of how it's impacting you. I really appreciate that. I haven't felt once during this town hall that they were just kind of general gripes about the program. You all have provided a lot of really great information to help us move forward in a productive way. So Shelley, she has I can know that her ideas are in the chat box, but one idea that she had was that perhaps we could break out and do some additional meetings outside of these, well, I would say outside of these town halls on maybe some waiver specific needs. Does everybody think that that sounds like a good idea?
Absolutely.
I think you'd find the inequities and the differences and what people need would be a lot better, because like what a lot of these people speak of, I don't need, and what I'm speaking of, they don't need. And so I think it would help a lot to have, but HT waiver is very different because there's a variety of people, so that's going to be tricky. But somebody living with a disability and a parental advocate is a very different aspect. So I'm not sure the best way to go about it, but I think it would help a lot.
Well, we can certainly take a stab at it and then tweak it if we need to. So
Right.
I would love to do that. Are there times of day that work best for all of you? Do afternoons and evenings work better? I'm sorry, Garrett.
Anytime, any day.
Okay.
As long as we get a chance to.
I can get off work
I
for
can
something
narrow
like this.
down specifically for you because it's a wide range of different issues, but it's just simple. Instead of making it so complex and so complicated, it just would mean a lot to us if we could speak to you, whether it's a small group or what have you, a handful or a dozen people. That would be great. So
Okay.
I would just go out on a limb and I hope not to speak for every physically disabled person in Iowa, but typically we have home health care in the morning, and a lot of the agencies right now are understaffed for a variety of reasons, which we'll talk about another time. But you know, so afternoons and evenings are typically best, we've found, whenever we've tried to have advocacy meetings like this.
Agreed.
Great. Great. Well, we will get.
Thank you so much.
Hey,
Thank you.
This is my responsibility, and I really appreciate all of you. And we have a lot of work to do together, and I'm going to need a lot of good ideas and ways in which
Thank you for listening.
For having this.
Yes.
We all appreciate it very, very much. We've needed this for a while.
I agree. Thank you.